Our guest today is one of the most influential digital leaders in the NHS right now. Amy Freeman is the CDIO at University Hospitals of North Midlands and was recently named CIO of the Year. She's led pioneering AI programs, championed digital transformation from the inside out, and built a local strategy with national impact. She's shaping the future of digital healthcare, and we're lucky to have her with us. Amy, welcome to Block's Future Now. We've known each other now for probably 3 or 4 years, and I've been really looking forward to this interview because it gives us a chance really just to reflect on how far you've come over the last couple of years and everything you've achieved. And I know there's a lot coming down the line as well, so we're always really excited to hear more about that. But I guess there's probably no better place to start than your recent recognition as CIO of the Year, and congratulations again on that. But what does that mean to you and the team?
I think for me personally, to be recognised by your peers, and there are some amazing CIOs in the NHS, absolutely amazing. So to be recognised by them, really proud moment. I was gutted not to be there because I was in Egypt at the time. So my Chief Medical Information Officer went and collected the award for me, but it is now in my office. My Chief Exec gave it to me formally the other day, and really, really proud.
Oh, that's nice. And I guess you've done so much in that time, but what would you say, you probably don't want to reflect too much on this because I know you, but what would you say your proudest achievement in getting to that point would have been?
I know this is a sponsored by Block, right? But the network migration has been a massive thing for the hospital, a really big thing. Without that, you can't build anything else, can you, if the foundations aren't in place? So migrating the network last year was a really big thing for me. Securing funding for our electronic patient record is another thing that's really important to me. And the work that we've been doing around the patient portal and giving patients access to their record, again, that's been a big thing for me. So probably too many to list, but there's been quite a few moments that you just go,
Yeah, that's good. I mean, it wasn't that long ago, really, that CIOs weren't at board level in trust, so there's been a huge change there. What do you think that sort of shows the way NHS is going in this country and how the changes have happened?
We've seen it a bit, haven't we, with the 10-year plan, right? That says one of the key elements is to go from analogue to digital. And if you don't have somebody who understands digital well at the board, you're always going to invest in bricks instead of clicks. And for me, that's not a good place to be. And when I first joined the trust I'm at now, we were talking about, do we need a car park? And because I was at the table, we were able to really debate, well, actually, if we transformed our services and delivered care in a different way, closer to home, less face-to-face appointments, using video technology, do we need to build a new car park? And unless you're at the board, you're not going to be privy to those types of conversations. So I think it's really critical, and will be more critical as we move forward with the 10-year plan. That literally calls that out as one of the 3 key pillars, doesn't it? So I think it's going to be really, really key.
That's good to see.
And it has, like you say, it has increased. So it's good to see that, but it's not everywhere, and there's still work to be done.
One of the things I've been really impressed with what you've done at UHNM, and we were involved in a couple of these, is the Digital Advocate Day that you put on, and I couldn't believe when I attended just the amount of staff that you have there, just the level of engagement that they have with the ideas and the sharing and the discussions that happen there. Can you tell us a little bit more around how you do those sessions and kind of where they came from?
Yeah, so the Digital Advocate Network was set up when I first joined UHNM as a way of stakeholder engagement across any grade, any staff member, any type. We'd got really clear paths for how we engage with medics. We've got really clear paths with how we engage with nursing. We hadn't got that across the board. And actually, some of the ideas that are your best ideas will come from a Band 2 administrator on a ward, or will come from an AHP doing physiotherapy with a patient. So the ability to be able to get a cross-section of users of our service together and get those ideas flowing is really important. It's also, without wanting to be blunt, a really good way of getting comms out there cheaply, a really good way of getting floor walkers when you've got big go lives, a really good way of doing train the trainer. So you train your digital advocates and they will then go and train. So it was a really good vehicle for multiple purposes. But the key one is engagement and help setting the strategy. And when I landed at UHNM, we had a strategy. It was coming to the end of its life. It was in its last year. And it would have been easy for me to sit in a darkened room and write one and go, I know what the NHS needs and be a bit arrogant about it. But the reality is I was new to the organisation, so I needed to get real voices into that strategy, and setting up the DAN was part of that. So the quid pro quo for the DAN is they give me their time and opinion and ideas, and I give them free lunch at the DAN day every year. And so the one that you're referring to was our third DAN. And they've just got bigger and better year after year, and people are coming and they're more empowered. They've got a greater voice. They're happy to talk up. They're happy to run sessions. You know, the sessions that you were part of, some of those were run by members rather than by digital teams. And that's a really, proud thing for me. So really important network. And these are people who give their time voluntarily. They're not given time in their day particularly. So we have to treasure them and support them, but give them a voice.
Could you share some real world examples of how you've helped frontline staff as well?
Yeah, so in not the last DAN day, but the DAN day before, we had a nurse who was leading on an initiative to get patients moving. So one of the things that really impacts patients is when they get admitted to hospital, you get put in a bed, you get fed 3 times a day, you get watered regularly. You don't actually have to move out of your bed. But that causes deterioration, and quite significant deterioration in quite a short period of time. You only have to be in bed a few days before you are genuinely losing kind of muscle mass. So she was working with Johns Hopkins about getting people moving and setting movement goals. And they were recording this on paper. And she said it'd be really good if we had some kind of app that would allow us to set goals for the patient, identify their capabilities as they come into the hospital, set goals for them to keep them active during their time in hospital, so we then avoid that deterioration. There wasn't an app that existed. She came with the idea and worked with my development team to build an app, which is now in live use. And interestingly, the Johns Hopkins stuff comes from the States. They don't have an app in the States either. So this year she went over to the States and showed them what we'd developed, and they were absolutely amazed. But we've got real evidence in how length of stay is reduced for those patients who are mobile. We've got evidence around muscle mass not deteriorating in those patients. So that's for me what technology should be doing. It should be making a real tangible difference to patients, and the infrastructure is absolutely critical to deliver that, right? But that's where the good stuff happens, and that came out of the DAN.
That's really helpful. I hope we can see more of them across the country as well. I'm going to move on to the PFI contract transition, which is probably one of the areas we've been so heavily involved with Block as well. When we first met years ago, it was probably one of the biggest challenges you had, I think would be fair to say, in that there were so many digital initiatives and things that you wanted to achieve within the trust, and you were being held back almost by a network that was, a contract that was designed for something that was so outdated. And there was that real need to try and modernise and create this stable foundations. But one of the biggest challenges you obviously faced was trying to take that back in from a PFI, which was, it's no small feat to try and overcome. So now you've taken back control of that. Can you talk through how that journey from PFI and the transition worked?
Yeah, so it started with a really good relationship with the director of estates, so my opposite number in estates, who runs that PFI contract. And our contract runs until 2044 for some elements and 2045 for others. So we're talking about long contracts here that is very difficult to come out of. And usually if you want to take a service out of that contract, you have to pay losses to the supplier because they signed up until 2044 and they would have made a profit, and therefore they're entitled to that profit. So really quite challenging. Now I'm not going to take credit at all for any of the negotiations because Lorraine mastered this completely. So she went in to those conversations saying, look, it's a pain for you, because they were having outages, and it's not good. You know, they didn't enjoy the outages. They weren't there laughing, you know, going, ha, 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 the network's down again. They didn't want that either. Yeah. So she knew that they were a challenge. So she went in and said, look, this isn't working for you. It isn't working for us. What is the art of the possible? And she negotiated that position where they agreed to transfer the service to us. And the charge we ended up paying was for the assets that were part of the service. So we would have needed those assets anyway, right? So for us, that was a real win. And she absolutely smashed that negotiation. So the biggest problem then was, how do we physically do it? You're migrating a massive network. We're a major trauma centre. We're a tertiary centre. We do, you know, really significant clinical things. You can't have the network down for, you know, several days for transition. So that's when we worked with yourselves on how can we do that safely in a big bang, because we'd got a deadline for that contract. We had to get out. There was no wavering of that. If we didn't get out by that point, we would have been stuck for a further 10 years. That was the commitment. So very tough deadline. But we then had to come up with a plan of how we were going to do that migration. And with block support, we came up with that plan. We were really, really lucky because some of the staff who'd worked on the network as part of the PFI came over as part of TUPE, so we didn't lose that historical knowledge. And again, those guys have been invaluable as part of that migration, been really valued members of the team. And we started to build a team in-house. And we've been really lucky to get some talented people. And I think we were able to secure that talent because we were doing something significant. We were essentially offering them a blank sheet of paper. And how often do you get in the infrastructure space where somebody says, design it how you want it? Very, very rare. Usually you inherit stuff and you're having to cobble together. We didn't do that. So we were able to secure some really good talent and manage that migration. We didn't have any outage as part of the migration. It was completely seamless. And now we're in that improvement leg, and we're seeing real improvements on the network.
It was, because I remember there was so much work went into that in the year and prior to that, leading up to there. But I remember speaking to you a couple of weeks after the migration or the transition had finalised, and it almost felt like you just managed it so well at that final point. Everything went smoothly. I know it probably wasn't in the background, but it was just great to see this, you know, what you achieved at that point.
I don't think our users even knew.
Yeah.
Right? And so you do all of this work, don't you? Put loads of effort in, loads of testing, loads of rehearsals, and you're kind of expecting this big crescendo, aren't you? But nobody knew. Now that is a sign of success as it happens, isn't it? Right? But you kind of, okay, we've done it.
There's been so many improvements since then. But if you could summarise kind of the biggest thing that you've seen since taking back that control, what would that be?
We don't have the outages that we were having. So we were having outages every month. And that is crippling for a hospital, absolutely crippling. So that was our first thing. Now, that wasn't a technology change. That was a process change, making sure we were doing change management well, using our standard processes that we use for other infrastructure from day one. And we really did eradicate that. Not saying we don't have the odd blip. Of course, that is to be expected, but we don't have 2-3 day outages and haven't. Touch wood, we've got some real wood since the migration. So that is number one. Number two, we've been able to increase the throughput and capacity on the network. Again, invisible to users. They don't sit there and go, ooh, look how fast I am. But we've been able to do that in readiness. So things like increased use in PACS, where we're trying to put more images into PACS from other modalities. We've now got the bandwidth to be able to support that on the network, whereas previously we wouldn't have had. So the ability to do that with PACS, the increased capacity. We've also started to improve the security position massively. So we're starting with doing segmentation now. So we're able to segment what network traffic runs on what bit of the network, and that really improves security. And where we look at medical devices are so connected now. In fact, it's quite rare to buy a medical device that doesn't want to connect to Wi-Fi or have some kind of network connectivity. And historically, they were all sat on the same network, so we're able to segment that now. So some big improvements we've been able to make, but often invisible
Yeah.
to the end user.
Yeah.
That doesn't mean to say it's not hard work, because it is.
Yeah, I agree. And they'd know if the network slowed down.
Exactly.
If,
Yeah.
the outages.
Exactly.
We talk a lot about networking throughout that, but also the control came back for the telephony and the unified comms estate as well, which is, I know you have more plans in that area as well. Could you maybe touch a little bit around kind of what you've achieved there so far and what's to come there as well?
Yeah, so this is a bit of a sensitive topic, because we have had a critical incident on our bleep system only since I came back from holiday, actually only in the last 2 weeks. So, and when the bleep system doesn't work, again, you are in critical incident.
Sure.
It is serious. So having the new network is allowing us to look at different options for replacing our bleep system. We've got a very traditional bleep system, as a lot of hospitals do, but having the new network and the resilience in the network is allowing us to look at alternatives. So, but let's park the bad news, right? Because that has happened, and we're working on it. In terms of the good news, we had a very segregated telephony service. We had our telephone service at County Hospital, which is one of our sites, and a completely separate one at Royal Stoke that had tenuous connection, but it wasn't a real connection. So that's now been resolved. We're consolidating that. We've been able to connect Microsoft Teams calling into our Cisco environment, so you can now sit on a Cisco phone and call somebody on Teams, and vice versa. That's really allowed us to consolidate the type of systems we've got and the volume of phone numbers that we give to people. We've not done it yet, but also part of that has enabled us to then go, well, who needs a mobile phone? Because if you can do Teams calling and that is fully integrated with the Cisco telephony service, do you really need a mobile phone? You could just run the Teams client on your phone and take calls through that. So it's allowed us to look at how we consolidate the number of direct dial numbers we've got across the trust. The call quality is improved, and the ability to do follow me is now in place. So we've made quite a lot of improvements quite quickly in that space.
So I remember you had so much pain with the telephony system when we first met. The limitations you had with, I think it was single number each and things like that used to drive you mad. So yeah, it's great to see you again. And I mentioned earlier around when we first met to take back that control, it led to the ability to be able to go and drive some of the digital initiatives, none more so than the EPR platform and the plans there. Could you maybe tell us a little bit around where you are on the EPR journey and how you were looking at this at a regional level as well? Yeah,
so our contract with our current provider ends in September 27, and we want to have real ambition to look at a system-wide EPR capability. And the reason we want to do that is part of the switch from analogue to digital, that's in the 10-year plan, but also part of the development of neighbourhoods, so the ability to have pathways, clinical pathways that are for the patient, that regardless of which organisation provides bits of support along that pathway, there is a single system that supports it. At the moment, that's not the case. So you'll go to your GP, the GP thinks you need something in the community, they'll send a referral and throw you over the wall. They will pick that referral up and they'll do some work with you, and maybe you actually need some more critical care. So they'll ask the acute trust to get involved. They'll create a referral, throw you over the wall. We'll do our bit and fix you, or whatever it is we've done, surgery or whatever. We'll then put you into rehabilitation, and we'll want you to go back into community provision because you don't need to be in a hospital anymore. We'll do a referral and we'll throw you over the wall. You can see how kind of disjointed it is. So we wanted to get to a stage where a single pathway, regardless of the organisation providing those steps, can see everything. They don't have to do referrals. They don't have to do handover. They just go, right, I'm ready for the next bit, and the next bit happens to be in your organisation. So that's the aim and the vision. And that came out in the work in the 10-year plan for neighbourhoods. Now, we decided that in 2021. That's how long we've been trying to drive this. So I don't know whether they stole our idea or we stole, but regardless, it aligns beautifully with that aim, and the aim of trying to get patients out of hospital and cared for in the community. But without that information flow and the workflow that sits behind, it's not just visibility of the data, it's the ability to do tasks and to record things. That's going to be critical. So that's where we want to get to. We've done soft market testing to look at what suppliers can support in that space, and that was really encouraging. So we're now just waiting for the 10 billion that's coming out from Treasury to be allocated formally to NHS England, and for them to decide how they're going to split that up, and hopefully we'll get some of that funding to allow us to move forward.
Yeah, hopefully so. show. And I can't get through any conversation at the moment without mentioning AI. I remember at the first Dan Day I came to, which was probably 18 months ago now, I think it was Dave Tudor stood up with a number of things he'd been working on in AI that he was adopting and trialing and looking to roll out across the organisations. And I was amazed at just how early you'd got on some of the adoption and how much you were embracing the technology and what was coming down the line. What makes your approach to AI differently, and how are you doing it to make sure it's safe and effective for people?
So I don't know how different we are to others, but we've recently had approval to set up an AI team.
Yep.
That's a multidisciplinary team. So we've got somebody there looking at ethics, we've got somebody there looking at data science, we've got somebody in there looking at the technology stack, we've got somebody in there looking at business change, and we've got somebody in there looking at information governance and the standards associated with AI. So it's a team sport. We had that business case agreed this year, and we're out to recruitment for some roles, and we've got some of those roles now in place. So our AI lead, for example, has now started with us. We already had 11 AI products and solutions in use, but they hadn't been through any kind of formal rigour and governance. So the first job of that group is to make sure we didn't introduce anything daft. Sure. I don't think we have, but we need assurance, don't we? You can't just assume that everything's okay. So the first job will be that. They're also looking at ambient voice technology. That's a big thing nationally. So we're involved in that. We're really excited about the stuff that's coming with the agentic, and particularly the voice-enabled agentic services. That's something that we're really, really optimistic about and excited about. So, and you've just got to give it a go, haven't you? I think what we're trying to create at UHNM, and we are a university teaching hospital, so this has to be our culture of trying. Yeah. And it's okay if you fail, as long as you fail pretty quick and you don't blow a load of money in the process. Failing quick, learning from that, reiterating, I think is where we need to be at. So that's what we're trying to build at UHNM.
Could you share a little bit more as well around your vision for agentic AI?
Yeah, so there's a couple of areas that I think will work quite quickly, stuff we can get in place really quick. So one is around consuming trust policies and being able to provide guidance on those trust policies to staff. It's very difficult. We must have, maybe 500-600 policies in the trust. We're expecting staff to read and digest and understand every single one. Forget it. That's not a reality, is it? So how can we stand up a service where they can ask questions and go, at UHNM, what's the policy on? At UHNM, how much annual leave am I allowed? At UHNM, what happens if I encounter an incident? And be able to use data from our policies to be able to inform that question. So we've been working with yourselves on a proof of concept in this area. We focus particularly on HR policies to start with, but we want to grow that and be able to have a line, a telephone line where people can ring in, have a reasonable real life experience, and it's pretty close. I mean, you do know you're talking to an agent, but it's pretty close. But to be able to have a conversation with that agent and then be able to offer information back around our policies. And so far, the demos that we've done on that have been really, really well received. We'd then like to take that a step further and use it in the clinical space. And there's two main use cases for the clinical space. One, for us to be able to put our clinical guidelines into the system, and for medics to be able to ask it. So, if I'm giving this amount of medication and the patient weighs this, what should the dosage be? So be able to use our guideline information and be able to provide support and guidance to clinicians. And then the other is, how can we provide support and guidance to patients? So if I take an example, and I use this example a lot, but endoscopy. When you have an endoscopy, you are given a prep solution to take a number of days before your exam. You take that solution, and if you don't take that solution, you can't have your exam. We get tons and tons and tons of calls from patients going, I've lost the prep. I can't remember when I'm supposed to take the prep. What if I take the prep too early? What if I take the prep too late? And if we could put that guidance into agentic. So the agent, the automated agent, is giving that advice and guidance. And only when it's a very complex case would they then break out to a human to get that advice. That's going to save our clinicians a load of time and potentially move those procedures that when they turn up and go, oh, I didn't take it, well, that's a lost slot, isn't it? That's a lost. So hopefully we'd be able to have a better rate of procedures because people will know what they're doing, know how to get that advice and come ready for their exam. So those are the types of use cases that we're thinking at UHNM.
You can see how they'll make a real impact. So Amy, the NHS is always under so much financial pressure. How are you managing to get so much done?
I mean, it doesn't feel like we're managing to get as much as I'd like to get done. And our cost improvement targets this year have been the hardest they've ever been. And it is difficult. I mean, luckily, I've got such a great team who can come up with ideas of ways of saving money. And organisationally, we've come up with a bit of a deal that the savings don't necessarily have to come out of digital. If we've enabled those savings in another team, then we can kind of take a bit of a gain share approach to that. So trying to be a bit novel in the way we do our CIP, because otherwise digital just shuts its doors and that then can't enable savings in other areas. So rather than doing that, we've agreed with our chief finance officer that we have this kind of gain share arrangement. We've also had a fair bit of practice. So historically, UHNM has been in financial special measures for a number of years. So we're not unused to having to work with very, very tight budgets and even be finding ways of offering money up. The consequences of that is you end up with a lot of point solutions. So we've got 405 IT systems in use at UHNM, and that's probably 400 too many, maybe not. But way too many. And that causes complexity. It means we've got data in silos. It means we've got a very fragmented pathway for some services. So there are consequences of doing that and sort of only buying the thing you need for that particular purpose and not taking a more strategic view. And we're suffering because of those years in special measures where we've had to make those tactical decisions. But when you're then asked to give up more money, you can fall back on to the techniques and methods that you've used. And the team are really talented at coming up with ways to save money and reduce costs, either directly in our area or in others. But it is tricky. And when you've got the 10-year plan that says you need to shift from analogue to digital, yet one of the first places to get raided is digital, that kind of doesn't really align. So it's tough. But we've kind of done it before, and we'll deliver our CIP this year. Challengingly, we will. But the team are what make it work. They come up with the ideas, they execute those ideas, and they are fab.
So Amy, final question, and what are you most excited about that's coming down the line soon for you then?
Yeah, so a couple of things, and again, very different examples, but a couple of things that are happening soon. We're about to go live with our electronic prescribing and meds administration system. This will see us moving away from paper charts, drug charts, to digital charts, and we're really excited about that. We have had incidents in the past that have caused challenges for patients because of they've not had their medication, or they've not had it in time, or they've had the wrong medication. So being able to put in a system that allows some guardrails around that is really helpful. We also believe there's some cost savings to come out of that as well, because we can design a formulary that allows us to pick the least expensive drugs, and the most expensive drugs just won't be selectable, so they'll have to use the cheaper drugs. And in some cases, we're going to be able to say only certain people can prescribe that particular thing. So we believe there's some cost savings to come out of that. Heavily reliant on the network and infrastructure, because it's all done on an iPad type thing, very mobile, by the patient's bedside. So that's really key that we get the network, the Wi-Fi network in particular, in a good place for that. And luckily the work we've been doing over the last 12 months has allowed us to be confident in that. The other thing, again, totally different, our guest Wi-Fi. So we historically have had a contract with Wi-Fi Spark, who have provided us a perfectly reasonable Wi-Fi service. But there are challenges with that service. So patients, our demographic of patients is really varied. They don't necessarily understand technology, and therefore when they connect, under the old system, they were asked to register, validate an email. If the email went into their junk folder or they didn't realise, they'd get kicked off the network. And we can see that in the data that shows that people connect but don't stay connected. We don't think that's because they've just had enough. We think that's because they've forgotten to follow the full process. So we've been able to change that completely. So patients don't now need to do that registration. They don't have to go and hunt for an email in their inbox to connect. They're on, they click yes to the terms and conditions, and they're straight in. We've also been able to massively increase the bandwidth available. So now they don't have to pay a subscription for extra bandwidth. They can download and play stuff on YouTube. They can use a Netflix account if they want to. They can use Sky Go if they want to. So really, really good for our patients. But we also offer our staff the same service. So when you come into our hospital, like many hospitals, it is essentially a Faraday cage. There's no 4G penetrating that building, certainly in the depths of the building, just because of the way it was architected and designed. So people rely really heavily on that to be able to connect their personal phones and be able to talk to each other, talk to their family. I'm staying late, being able to do all of those practical things. And again, they don't have to register in the same way. One click and you're on, and the bandwidth available to them is significantly bigger and more robust than it was. So I think that's really going to see an improvement for our patient experience and for our staff experience, but very two different examples. One really about clinical safety, improving quality, and one about improving experience. And I think trying to get that balance is key.
Yeah, I can imagine. And it's been so good to sit here and reflect on everything you've done. And I'm so excited to see some of these projects coming down the line and continue our partnership together. So thank you very much for your time today.
No, thank you for having me. It's been a really good experience. And this is a team sport, right? Whether that be a team sport with my team, the digital team, or with our partners like Block, it is a team sport. But I feel like we're really making a difference to patients at UHNM.
I would completely agree. Thank you.